Hi, for my presentation, I will be going over the use of orthotics for individuals with neuropathologies. I wanted to talk about the different approaches when it comes to the use of orthotics in clients with a neuropathology. There are essentially two lenses we can use, a biomechanical lens and a neurophysiological lens. The biomechanical lens focuses on the idea that the orthosis will provide stretch to muscles to minimize contractures, prevent subluxation, and secondary impairments due to the neuropathology. There's a lot of evidence out there on this, and a lot seems to be in favor of it. However, this is not going to be what we focus on, as that was what we learned last semester in ortho. I will be focusing on the neurophysiological lens. The main question we will be focusing on for this presentation is, do orthoses have a place for individuals with abnormal tone? Or in other words, do orthotics influence tone by either inhibition or facilitation? Also, I'll be focusing on upper extremity orthotics as it seemed a little bit more OT focused. However, we should still be looking at and for the evidence on anything our clients may have. Also, just as a note, constraint-induced movement therapy is not the focus either. I don't want this to be confusing, but sometimes an orthosis is used as the means of constraint, but this is different than managing abnormal tone with an orthosis. Just as a quick review, a neuropathology is a condition that affects the central nervous system. It can include a stroke, traumatic brain injury, acquired brain injury, and cerebral palsy, among others. But these will be the main conditions I will be presenting research on. Again, a quick review on tone and what we have learned from class, but the main thing I wanted to point out here is that the goal for managing tone is either to facilitate or inhibit tone to achieve motor control. I will be reviewing the use of orthotics as an intervention to help with this. So what does the evidence say? Well, it's actually quite mixed. Some say that there really is not great evidence for the use of orthotics in the case of a neuropathology. Some disagree and suggest that the evidence supports it. A systematic review done by Tyson and Kent suggested that the use of orthoses in stroke patients is not effective in improving upper limb function, range of motion at the wrist, fingers, or thumb, and does not improve pain ratings. One of the articles in this review focused on spasticity and reported that no effect on spasticity was found. Another article determined that there was insufficient evidence to either support or refute the effectiveness of upper limb casting in the treatment of children or adults following brain injury, cerebral palsy, or stroke. Other studies I found came to a very similar conclusion. One mentioned splinting limbs affected by hypertonicity is unlikely to create permanent tonal changes because it does not have a permanent influence on the central nervous system. Another concluded, an overnight splint wearing regimen with the affected hand in the functional position does not produce clinically beneficial effects in adults with acquired brain impairment. On the other side, an article done by Langolis discussed how splints may have a place in changing the level of spasticity and how they provided a low-cost and non-invasive method for reducing upper extremity muscle tone following brain damage. Additionally, for reducing spasticity, a systematic review found low strength of evidence for the use of static and dynamic splinting and strong strength of evidence for the use of stretching devices. This will be covered more in later slides. Interestingly enough, our orthotics textbook from last semester had information regarding splint designs when it comes to creating a splint for a client with neuropathologies. According to our ortho textbook from last semester, design incorporating the neurophysiological perspective varies according to two different things: the location of the hand, wrist, forearm platform, and the configuration of the hand component, including the position of the digits. It went on to discuss dorsal and volar designs. The argument or research for the volar design claims that it sustained pressure on flexor tendon insertions, in which results in muscle relaxation. On the other side, the research they found argued for the dorsal design, saying cutaneous stimulation of the volar surface of the hand and forearm triggers greater spasticity. However, neither design has yet to be well proven, and there's no clear advantage to either one. When it came to the hand component of the splint, our textbook mentioned common designs that have been found in research, including the following examples on the slides. These designs appeared to have evidence supporting them. The textbook also mentioned a reflex inhibitory design that I wanted to mention briefly. It mentioned that it reduces spasticity and improves mobility. It places the wrist in 20 to 25 degrees of extension. The thumb is positioned in opposition, and the digits are spread with a dorsal cover to provide complete volar contact to reduce stimulation potential for reflex. While there was not much more mentioned about the design, it sounded like they were describing the design in the top picture. When I looked more into the evidence on the use of orthotics in individuals with neuropathologies, a lot of it was divided based on the type of splint. The first type of splint I'll be going over is a static splint. According to the systematic review I mentioned before, low to moderate evidence was found for the use of static splinting in reducing spasticity, improving hand function, and improving functional tasks. Additionally, evidence was found that a number of stroke patients do not tolerate a static orthosis over a long time period due to discomfort. In a descriptive study that included 11 patients, 4 of the patients wore the orthosis for at least 8 hours per day, all with good experience comfort. 2 patients, however, were unable to wear the orthosis prescribed 8 hours a day due to poor comfort. And 2 patients stopped using the orthosis, one because of an increase of spasticity and the other because of an increase in pain. They mentioned how the level of spasticity varies during the daytime, resulting in different positions of the wrist. With a higher level of spasticity of the muscles, the wrist tends to flex. However, the splint itself does not move. The researchers suggested a dynamic orthosis using the low load and prolonged stretch principle that we learned about last semester, with a hinge which allows the wrist to flex during higher levels of spasticity, may be more appropriate for these stroke patients in the study. Looking at the same systematic review, evidence found on dynamic splinting was also arranged from low to moderate. There was no significant changes in the modified Ashworth scores after 3 and 6 months of use, according to one study in the review. Another found moderate evidence as wrist passive range of motion, active range of motion, and grip strength increased significantly immediately after 1 hour of dynamic splint wearing compared to with static splint wearing. However, no other measurements were taken, and it was only 1 hour of wearing the splint. The last one found low strength of evidence with no improvement seen on the Fugl-Meyer assessment at 1 and 3 months. Also, I did want to make a quick note that this systematic review included 11 articles that met the inclusion criteria, and if you want more information on that, I put more details on the notes section of the PowerPoint. Stretching devices, by the definition provided in the article, almost sounds like a dynamic splint, but the article defined it separately. I found one of the articles mentioned in the stretching devices section of this review, and we'll be covering that on the next slide. The evidence here was mixed. 2 studies suggested a strong strength of evidence, while 1 suggested a low strength. The next slide will focus on one of the 2 articles that suggested a strong strength of evidence. This article actually came up a few different times in articles I was looking at, so I wanted to take a closer look at it. The 2 different colored boxes are about the same study, but just from different articles. But the original study included 11 participants who met the inclusion criteria of having a stroke onset less than 6 months previously. The age range was from 18 to 75 years. They had incomplete weakness of the affected wrist and the finger extensor to the extent of the inability to move without gravity. Severe spasticity of the affected wrist and finger flexors, rated by the modified Ashworth scale. And they also had no history of peripheral nerve injury or musculoskeletal disease in the affected upper extremity, no contracture of the affected wrist or fingers, and no history of any invasive procedure for treatment of spasticity within 3 months of the start of the study. People with severe apraxia, somatosensory problems, or cognitive problems were excluded. However, 1 participant was dropped out of the study due to a sudden aggravation of thumb spasticity before the static stretching program started. So it ended up just being 10 participants. And just as a note, the stretch state was maintained for 10 minutes, 1 session, and sessions were performed twice daily for 7 days per week for 4 weeks. There was no long-term study or data was collected. Also, all of the information is in the notes section of the PowerPoint. They found that spasticities of the affected wrist and MCP joints were found to improve after the 4-week static stretching program. Motor function of affected wrist and hand, measured using the Fugl-Meyer motor assessment, showed improvements after participation in the program, but active range of motion of the MCPs and wrist did not show significant changes. The amount of improvement using the Fugl-Meyer assessment was 13%, which was believed to be meaningful because the FMA improvement of 10% has been reported to be clinically significant. So overall, it was found that the devised static stretching device, which is in the picture, effectively improves spasticity and motor function in people with severe spasticity and incomplete weakness following the stroke. There was not much found on casting when it came for the use of orthotics through a neurophysiological lens. In the same systematic review I've been mentioning, 1 trial out of 2 that demonstrated positive effects found a small improvement in quality of upper limb movement, and another showed a short-term improvement in range of motion. Most of the evidence I did find on casting through the looking at research and everything specifically serial casting, had a biomechanical focus. I did want to include some evidence on the use of upper extremity orthotic use in cerebral palsy, because I know some of you are thinking that you never want to work with adults and might feel this is not relevant to you, which I totally understand, but this really is relevant and we should be concerned with the evidence still. An international multidisciplinary group of healthcare professionals and researchers participated in a consensus conference on the management of cerebral palsy put on by the International Society for Prosthetics and Orthotics. They discussed how a hybrid treatment approach of dynamic assistive bracing, coupled with electrical stimulation across elbow and wrist joints, appears to be effective in reducing upper extremity tone and improving dexterity and grip in subjects with hemiplegia, but the treatment effects has not been shown to endure once the modalities have been discontinued. Also, in a two-group randomized controlled trial involving 30 children, participants were randomized to either receive a customized functional wrist orthosis or did not receive an orthosis. The groups were divided evenly. The blocks and blocks test was used to administered at baseline and repeated 1 hour after experimental intervention, with the orthosis on if randomized to the orthotic group. After intervention, there was no significant differences on the box and blocks test between the orthotic group and the no orthotic group, and they found that wearing the functional wrist orthosis did not lead to an immediate improvement in the ability of children with cerebral palsy or brain injury to grasp and release. I do want to note, however, that the orthosis was only worn for an hour, and the study only focuses on the immediate effect. No long-term data was collected. This is not the exact focus of this presentation, but I thought that it was still relevant to address. Commercial splint makers and sellers are really jumping in on the neuroplasticity, trends, you could say, to help sell their products. Not to put them on the spot, because they actually offer a lot of really good products, but Sabo has an article that talks about the benefit of splinting in their products for the post-stroke population. To their credit, they really do only mention the biomechanical benefits as the ones that are definitely proven, but they did talk about how their products may help with, quote, reprogramming the brain, quote, and discuss neural pathways, task-oriented training, and all that. So it might not be super relevant, but clients we have might see this stuff and have questions, so it's important to be up with the evidence to be able to give them a decent answer. Results of the stroke rehab gloves in therapy have included significant increases on the Fugel-Meyer assessment and box and blocks tests, which are designed to test the elbow's control and strength during reach to grasp tasks. Reduced jerkiness of the wrists, shoulder, and elbow joints during reach to grasp therapy tasks. Improved flexion and abduction. Support for the hand and finger extension after loss of mobility. Increased motor recovery. Increased grip strength. Active improvement to the overall functionality of patient hands, with some enjoying nearly full functionality, and strong potential for future improvements of arm and wrist mobility. So this was actually really interesting because they're advertising it for individuals with neuropathologies, so I just wanted to make a quick note on that. So what does all of this mean for us? Really, we just need more evidence to support the use of orthotics or refute it in clients with a neuropathology. It would be helpful to see more evidence on dynamic splinting and stretching devices, as those were the ones that seemed to have some effect. There may be a possibility that we consider other interventions as well, knowing that the evidence does not fully support this in a full. It's important to note that stretching and splinting should not be used as a standalone intervention either. Also, more long-term studies would be helpful. Some patients may need extended use up to 6 months before improvements in post-stroke spasticity are noted with the use of static or dynamic splinting interventions. Also, stretching and splinting interventions alone may not improve patients' ADL ability, so that kind of goes back to how they shouldn't be used as a standalone intervention. We may need to use a modification or adaptation approach to intervention to increase ADL independence. Lastly, these are my questions for you to discuss in the forum. Feel free to ask about anything that was unclear as well. Thanks for watching, and these are my references.